Okay, let's dive straight in. Today, we're doing something really focused. It's for you listening, especially if you're trying to nail down your revision.
Yeah, absolutely.
We've got these revision notes here on oral cancer. And well, our mission today is to pull out the absolute key high yield stuff from them.
Exactly. Make it stick.
We want to make your revision, faster and just more effective. We're aiming to find those crucial facts about oral cancer that you really need to know.
Because revision notes, they're great, but sometimes there's just so much detail, right? You can kind of get lost.
Totally.
So we're going to try and clear a path through these notes, cover the basics, definition, causes, what to look for, investigations, management, all that.
Think of this as your shortcut, basically. We're not just reading the notes. We're digging into the key parts, pulling out what really matters. So let's get started. Unpacking these oral cancer notes. First things first, the definition. What exactly is oral cancer?
Okay, so at its core, the notes define it as abnormal, uncontrolled cell growth, specifically within the oral cavity.
Right.
It's part of that larger group, head and neck cancers. And the notes are really clear. The most common type, by a long shot, is squamous cell carcinoma, SCC.
SCC. Got it. And where do these SCCs usually start?
Well, they come from the squamous cells, those flat cells lining surfaces. So they can start in the oral cavity itself, the oropharynx, it's the back of the throat, the larynx, even salivary glands.
Okay.
But focusing just on the mouth, the oral cavity, the notes highlight the most common spots. That's the border of the tongue and the floor of the mouth.
Ah, okay. Tongue border, floor of mouth. Important spots.
Definitely. Although it's worth just mentioning, the notes do say melanomas, while rare can happen in the mouth too.
Good point. So why does this happen? What causes it? The etiology?
Right. The notes stress it's multifactorial. It's rarely just one thing.
Ah, so a combination of factors usually.
Exactly. It's usually a mix of things damaging the cells over time,
Okay.
and the notes list the big ones.
Let me guess.
Tobacco.
Top of the list, any form, smoking, chewing, doesn't matter. Then heavy alcohol use, that's another major one.
And something getting more attention is HPV infection, specifically HPV-16. The notes link this particularly to oropharyngeal cancer, but it's relevant for the oral cavity too.
Right, HPV-16. What else?
Well, poor oral hygiene comes up. Chronic irritation is another. Think like sharp teeth constantly rubbing, or maybe dentures that don't fit well.
Constant irritation.
Yeah, and betel nut chewing is mentioned. That's a huge risk factor in certain parts of the world.
Okay.
So all these things fundamentally can lead to genetic mutations in the cells lining the mouth.
So the DNA gets damaged.
Precisely. And these mutations mess up the normal cell controls. Cells start growing when they shouldn't, they don't stop, and eventually you get a tumor.
So understanding the why, the etiology, helps link those risk factors to the actual disease process.
Exactly. And that leads us neatly into the risk factors themselves. There's obviously a lot of overlap with the causes we just talked about.
Sure. So smoking, alcohol, betel nut, chronic irritation, HPV, those are the key ones listed.
Yes, those are explicitly called out. But the notes add some really important details here.
Yeah.
Pre-malignant lesions.
Ah, the warning signs before it's actually cancer.
That's right. Things like oral leukoplakia that often looks like a white patch, and erythroplakia, which is a red patch. These are crucial to spot.
And one is worse than the other, isn't it?
Yeah, the notes highlight that erythroplakia has a much higher chance of becoming malignant compared to leukoplakia. That's definitely a high yield point.
Okay, erythroplakia, red patch, higher risk. Got it. What else?
The notes mention something called an index head and neck SCC. Basically, if someone's already had one SCC in the head and neck area,
They're more likely to get another one?
significantly more likely, yeah. Often because the original risk factors, like smoking or drinking, are still present. Field cancerization, that's sometimes called it.
Right. Any other risk factors mentioned?
Yes, ionizing radiation exposure, certain occupational things like formaldehyde or wood dust, too much sun, especially for lip cancers, those can be melanomas, and simply getting older. Advanced age is a big factor.
And you mentioned HPV driving up cases in younger people.
Yes, the notes specifically point that out. It's a definite trend, changing the historical picture a bit.
Okay, so that gives us a clear view of who's most at risk and why. Now, the pathophysiology, how does it actually develop?
It's pretty brief in the notes, but basically it starts in those squamous cells. Chronic exposure to those risk factors we talked about leads to the DNA damage, the mutations.
Right, the uncontrolled growth.
Exactly. The cells divide without stopping, forming a tumor.
Mm-hmm.
And critically, these tumors can then, invade nearby tissues. They grow into things.
And spread.
And potentially spread. Yes, that's the metastasis part. The notes mention local invasion and metastasis, usually first to lymph nodes in the neck, but potentially further afield later on.
Okay, so that's the process. Now, let's look at the numbers. Epidemiology, the notes focus on the UK.
Yes, UK stats primarily, and these are definitely worth trying to memorize, maybe grouping them together.
Okay, hit me with the key figures.
All right. Around 8,800 new diagnoses each year in the UK. Lifetime risk. About 1 in 55 for men, 1 in 108 for women.
So roughly twice as common in men.
Yeah, and age is a big factor. Incidence goes way up with age. Around 80% of cases are in people over 55.
Makes sense with the cumulative exposure idea.
Exactly. But here's a worrying trend the notes highlight. UK incidence has gone up by 1/3 in the last decade.
Wow, 1/3. That's significant.
It really is. Globally, it's very common in places like India, but that UK rise is notable.
And you mentioned the demographic shift again.
Yes, worth repeating.
Yeah.
Still mainly older males with the traditional risk factors, but definitely seeing more cases in younger people linked to HPV.
Okay. And overall impact.
Accounts for about 2% of all UK cancer diagnoses. So maybe remembering the numbers as annual cases, lifetime risk, age group, and that rising trend. That might help.
Good tip. So we know what it is, who gets it, why. But when a clinician sees something odd in the mouth, it's not automatically cancer, right? Differentials are key.
Absolutely crucial. You've got to think about what else it could be. The notes list several possibilities.
Like what?
Benign oral tumors, non-cancerous growths, simple mouth ulcers, which are super common but should heal, oral candidiasis or thrush,
Right.
those pre-malignant things we mentioned, leukoplakia, erythroplakia,
Mm-hmm.
also oral lichen planus, sometimes just traumatic injuries, from biting your cheek or something sharp,
Okay.
and even other much rarer types of oral cancer. Getting the diagnosis right, or at least considering cancer early, is vital. You don't want to miss it.
Definitely not. So what are the actual signs and symptoms? The clinical presentation, what should you be looking for?
The notes give a pretty comprehensive list. Number 1 probably is a persistent mouth ulcer or sore, one that just doesn't heal after, say, 3 weeks.
That 3-week mark seems important.
It is. It comes up in the referral criteria later, too. Also, those red or white patches, erythroplakia or leukoplakia that don't go away.
Okay. Ulcers, patches.
Swelling or lumps. Could be in the mouth, on the lips, sometimes felt in the throat or neck. Difficulty swallowing, dysphagia, or difficulty chewing.
Functional problems.
Yes. Hoarseness or other voice changes. A persistent sore throat or that feeling like something's stuck back there. Numbness or pain in the mouth or lips without a clear cause.
Right.
And unexplained weight loss can be a later sign, often indicating more advanced disease.
So a range of symptoms. The notes seem to really emphasize that persistent mouth ulcer, though.
They do. It gets mentioned again later, along with a persistent neck lump and persistent sore throat as key red flags.
Grouping them might help memory, like visible changes, ulcers, patches, lumps, functional issues, swallowing, speech, and other sensations, pain, numbness, plus general signs like weight loss.
That's a good way to think about it.
Yeah.
And the location matters too. Tongue cancers often affect speech or swallowing early. Tonsil cancers might show up as a neck lump first or cause a sore throat or bleeding. Cheek cancers, buccal mucosa, often present with pain and ulceration.
Okay. So you see these signs, you've got your differentials. What's the next step for a definitive diagnosis?
Biopsy. The notes are crystal clear. A biopsy is mandatory. You need tissue to look at under the microscope to confirm cancer cells.
And they mention doing it under general anesthetic sometimes.
Yes, especially to assess the depth of invasion properly.
Okay.
That depth is really important for staging and prognosis.
Staging, right. That involves imaging too.
Absolutely. CT scans, MRI scans, sometimes PET scans, these are essential. They help see how big the primary tumor is that's a T in T&M staging.
Okay.
They check if it's spread to nearby lymph nodes in the neck, that's the N, and they look for spread to distant parts of the body metastasis, which is the M.
So the biopsy confirms cancer and the scans tell you the extent the T&M stage.
Precisely. The notes actually give some detail on the T staging based on size and depth. T1 is small and shallow, 2 centimeter, you're 5 millimeters deep.
Yep.
T2 is either still small but deeper, 2 centimeter, 5-10 millimeter deep, or a bit larger but still fairly shallow, 2-4 centimeters, 10 millimeters deep. And T3 is either large, 4 centimeter, or it's invaded deeply, 10 millimeters, regardless of the surface size. Knowing these helps understand the severity. The notes focus on T, but remember N and M come from the imaging.
Got it. What about finding cases earlier? Is there screening?
The notes say there's limited evidence for, like, population-wide screening programs, not like for breast or bowel cancer.
So no national program.
No. Instead, the emphasis is on vigilance. Dentists and doctors being alert during routine checks. Opportunistic screening, basically.
And that leads into the referral criteria. These seem really important, especially the timeline.
Extremely important. Definitely high yield. The UK uses a 2-week wait pathway for suspected cancer. For oral cancer, the criteria are an unexplained mouth ulcer lasting more than 3 weeks.
3 weeks again? Okay.
Or a persistent lump in the neck that doesn't have a clear cause.
Right.
And dentists have urgent referral pathways too. If they see a suspicious lump in the lip or mouth, or one of those red or white patches Erythroplakia or Erythroplakia that needs an urgent referral.
Knowing those specific criteria and the 2-week target is key.
Absolutely critical for timely diagnosis.
Okay, so diagnosis confirmed, staging done. How is it managed? The notes mention a multidisciplinary team.
Yes, strongly emphasized. MDT approach is essential. It's complex treatment. The main tools listed in the notes are surgery, radiation therapy, and chemotherapy.
And it's tailored to the patient.
Always.
Yeah.
Based on the cancer stage, its exact location, and the patient's general health. It's not one size fits all.
Who's usually in this MDT?
Surgeons, often oral and maxillofacial surgeons. Oncologists, medical and radiation oncologists. Dental specialists are vital too, before and after treatment. Nurses, dietitians, speech therapists, a whole team.
Right. And the specific treatments listed?
For radiotherapy, they mention external beam and also interstitial, which is brachytherapy, putting radiation sources right inside the tumor.
Okay.
Surgery is often en bloc resection, taking the tumor out with a margin of healthy tissue around it, all in one go. This often needs reconstruction afterwards, using tissue flaps.
Complex surgery?
Can be, yes. Myocutaneous free flaps are mentioned. They also mention transoral laser resection, sometimes used for larger tumors, though surgery is generally preferred for early stages. And chemoradiotherapy, chemo, and radiation together.
How does the stage affect the plan?
Generally, the notes suggest early-stage cancers are often treated with surgery first. If the tumor is deeper, it might be surgery plus removing neck lymph nodes, neck dissection, or adding radiotherapy afterwards.
And for more advanced cases?
Locally advanced usually gets multimodality treatment, maybe surgery, radiation, and chemo combined in some way. If surgery isn't an option, then radiation or chemoradiotherapy become the main treatments.
And supportive care is important too.
Vital. Speech therapy, swallowing therapy are specifically mentioned to help with function.
The notes also had that non-prescribing section with more management details.
Yes, it reinforced surgery as the mainstay, aiming for complete removal. It highlighted the need for reconstruction, and it mentioned the cervical lymphadenectomy debate.
About removing neck nodes.
Yes, but it clarifies that in the UK, elective neck dissection, taking out nodes even if they look clear on scans, is generally recommended for most oral cavity cancers, because the risk of hidden spread is quite high.
Okay, that's an important practical point.
It also mentioned adjuvant radiotherapy after surgery for advanced disease. Brachytherapy as an option for early stages. What to do if it comes back? Repeat surgery, brachytherapy, or external beam RT. And palliative options, radiation or chemo for advanced, inoperable, or metastatic disease, just to manage symptoms.
So a lot of options, heavily dependent on stage and the MDT discussion, grouping them by type surgery, radiation, chemo, and then by situation early, advanced, recurrent, palliative, seems like a sensible way to revise it.
I think so. And all this, the detection, staging, treatment, it all influences the prognosis.
Right. What factors affect the outcome, according to the notes?
The stage of diagnosis is the biggest one. Early stage, much better outlook. How deep the tumor has invaded the T-stage depth is critical.
Makes sense.
The patient's overall health matters. And crucially, how early it was detected. Plus, sticking to follow-up appointments after treatment.
It really reinforces the importance of spotting it early and getting that referral in quickly.
Absolutely. Which links back to prevention. What can actually be done to lower the risk?
The notes give some straightforward advice here.
Yeah, pretty standard stuff, but important. Avoid smoking completely. Limit alcohol. Keep up good oral hygiene, regular dental visits.
Any diet advice?
It mentions more fruits, veggies, fish, less high-fat meat, cholesterol, rice, refined grains, general healthy eating principles, really.
Okay. And finally, complications. What are the potential problems that can arise?
These are important for patient care. They can be from the cancer itself, like invading nearby tissues or metastasizing to lymph nodes or elsewhere.
Or from the treatment.
Yes, and just the functional impact. Difficulty swallowing or speaking is common. Cosmetic changes, deformity can really affect quality of life.
I can imagine.
Treatment side effects, of course. Dental problems are a big one, especially after radiation. Nutritional difficulties because eating is hard. And the emotional and psychological toll is significant too.
Understanding those helps manage the patient holistically.
Exactly.
Right. Well, I think we've really unpacked those notes. We've gone from definition, causes, risk factors, how it develops, the UK picture, what else it might be, the symptoms, investigations and staging, the whole management strategy, prognosis, prevention, and those complications. Tried to pull out the really high-yield bits for you.
Yeah, hopefully hitting those key connections, cause, signs, stage, treatment, and remembering those UK stats and referral times makes revision a bit easier. It's about linking the facts together.
Definitely. And just to leave you with something to think about based on what we've discussed, given that rising incidence in younger people, the HPV link, alongside the traditional factors, how do you think public health strategies need to evolve, for prevention and early detection, considering these changing patterns?
That's a really important question, something definitely worth mulling over as you finish your revision. It has real implications for how we approach this disease in the future.
Absolutely. Well, we really hope this deep dive has helped streamline your revision on oral cancer. And if you are prepping for exams like the MSRA, don't forget resources like passthemsra.com and freemsra.com could be really useful additions to your study plan.
Yeah, definitely check those out. And good luck with all your revision.
Thanks so much for joining us for this deep dive. Keep up the fantastic work.